Hi folks, this is Professor Elliott. We're going to talk about chapter 24, the neurologic system. So it's important to know what some of the areas of your brain do. So I'll show you a little picture on the next slide about that. I think the dermatomes are very interesting. This is kind of how we get sensory information. So let's say somebody has damage. These are your spinal nerves. So let's say somebody has lower back pain and the damage is at L4 or L5, let's say L5. So they may experience pain in this pattern of this yellow line on the leg. So these dermatomes are your spinal nerves, and each specific area innervates or gives sensory information to those areas. All right, so with your brain, you can look on page 625. It tells you about each of the lobes. I found this picture, I think it's nice. So the frontal lobe here in red, the frontal lobe is in charge of thinking, speaking, memory, and movement. So personality is here. We call this like your executive function area. This is where any intellectual functioning occurs, behavior. So memory. So remember, memory is here. Your parietal lobe is on the top. It is important for sensation. So taste, touch, and smell. Occipital lobe is in the back. This is your visual area, so it can recognize colors and letters. And then your temporal lobe is in that dark purple color. This is in charge of auditory information, also hearing, learning. Your cerebellum is on the back of your brain. It is in charge of balance and coordination, equilibrium. We'll talk about this rapid alternating movement test that you may have done in lab, or the Romberg's test. Really what those are checking is, kind of position in space and balance. And then your brain stem is responsible for breathing, heart rate, temperature, and blood pressure. You can read more about neuroanatomy, some information about the cranial nerves on page 631. All right, so let's talk about some subjective data here. So subjective data starts on page 634. You could ask about headaches. Headaches are a common complaint. We talked about migraines and what those feel like. They're unilateral throbbing that move across the head. Now, any patient that says this is the worst headache of my life, we're really concerned about bleeding in the brain or stroke. So anytime they say that, just know that's a red flag finding. That's really important. Ask about any history of head injuries or current head injuries. So a concussion is something that comes from a direct blow that causes the brain to basically hit parts of the skull. I think of it as kind of a bruise on the brain. Concussions can have lasting effects, and the more often somebody hits their head or injures their head, the more damage is done to their brain. So we've heard a lot recently about professional football players having very early onset dementia. The thought is it's just that chronic trauma to the brain that's causing that. So you really, in terms of safety, and we kind of talk about environmental and occupational hazards, you really want to ask patients who are playing sports or doing anything that could be dangerous if they're wearing protective headgear. So a helmet, something like that, that's going to protect their brain. All right, with dizziness and vertigo, you want to ask the patient if they've ever felt lightheaded. Syncope is basically passing out. We call it loss of consciousness. And then vertigo is rotational spinning. That's typically what we kind of think of with dizziness. Syncope, we may see like lightheadedness, and patients may describe that as dizzy, or patients may describe the room as spinning around them. So vertigo can either be from your inner ear. That's a big part of balance, or in your brain. So that's something to take seriously. With a seizure, I have highlighted aura there. So an aura is a subjective sensation that precedes a seizure. So it may be like colors, something somebody hears. It's something that tells them that the seizure is going to happen. So you want to ask patients if they have auras prior to seizures. So ask them if they've ever had seizures in the past, if they've currently presented with a seizure. Ask if anything, makes it worse, anything makes it better. Are they taking meds? The next one is about tremors. So tremor is an involuntary shaking or trembling. You want to ask them if they occur at rest or they occur when somebody's doing something. So tremors that occur at rest are associated with a condition called Parkinson's. Tremors that occur with intention. So like, let's say I'm reaching up to grab a cup, or I'm drinking out of a cup. If the tremor is made worse with intention, we call it an essential or familial tremor. So this is not Parkinson's. It's disruptive, but it's not, it's relatively benign. It's important to be able to differentiate between the rest and the intention. And then ask about weakness. So any difficulty moving a part of the body. If somebody has had a prior stroke, they may be paralyzed or unable to move one side of their body. So that is important to know. And then you can ask about any problems with coordination or balance. When asking about numbness and tingling, you are asking really about paresthesias. So that's a term that just means an abnormal sensation. They may describe it as burning or tingling. You can ask about difficulty swallowing and then difficulty speaking. And that is wrong, so let me correct that. So difficulty swallowing is dysphagia with that G. I always think gulp. Dysphagia with an S is difficulty with language. It can be understanding language or speaking. And then any environmental occupational hazards, I already mentioned that, but with contact sports or conditions that can result in head injury, you want to make sure that somebody's wearing a helmet. And then if anybody's having memory issues, you can think about the frontal lobe. So I would highlight that for the exam. So here we go again, difficulty swallowing, dysphagia with a G, difficulty speaking, dysphagia with an S. So I'll just write that in here. So I think of gulp. So G for gulp when we swallow, and S for speaking. And it's difficulty interpreting language as well. So one of two things. Okay, so some changes with age that's important to know. Patients may need glasses. We talked about some visual changes that occur after the age of 40. Patients may also take a little bit longer on mental tasks. So maybe completing a puzzle takes a little bit longer than it used to. And some mild hearing loss that can occur with age as well. So it's important for you to recognize some normal things and then abnormal things. So memory loss is not typically a normal sign that may be indicating dementia, but taking a little bit longer to maybe like complete a crossword puzzle, that is a normal kind of expected finding. So we have done the cranial nerves in lab, or at least you've seen them on the head to toe assessment sheet. So this is a cute little thing, and I learned this little facial drawing when I was in school. I think it's helpful. So we can see here, so I'll go through the cranial nerves and talk about what they do, and then we'll talk about some more neuro testing. So olfactory measures the sense of smell. We don't have that in the head to toe, but you can have a patient smell coffee or some smell that is common. So olfactory is 1, so you could draw a number 1 for the nose. Optic is number 2. So the optic nerve, you can test visual acuity. You can also do the visual fields by confrontation when you're checking the peripheral vision. And then cranial nerve 3, 4, and 6, remember they all go together to check extraocular muscles. So cranial nerve 3 is oculomotor, cranial nerve 4 is trochlear, and cranial nerve 6 is abducens. These nerves also are important for checking pupil size. We can check our extraocular movements by the cardinal positions of gaze. So remember, that's when we're kind of doing that X pattern where the person's looking up to the right, looking up to the left, looking straight to the left, looking straight to the right, looking down to the right, looking down to the left. Cranial nerve 5 is the trigeminal nerve. This has motor and sensory function. So with cranial nerve 5, you'll put your hands on the patient's joint, their jaw joint, and have them bite down. That masseter muscle should flex on both sides. And then you can feel the temporal muscle, which is around the forehead, that should flex as well when you are having them bite down. And then with the sensory function, the sensory aspect of the trigeminal nerve, with the person's eyes closed, you can tense light sense. And I would touch the top, so the forehead, the chin, and the cheek and the chin. So you can see in your book on 639 that there's 3 divisions of the nerve. So you would want to check, you're just checking light sensation on the forehead, the cheeks, and the chin. Cranial nerve 7 is the facial nerve. So assessing facial symmetry is important. When we're assessing somebody for a stroke, we will often see a facial droop, and that's important to know. So having the person smile, raise their eyebrows, puff out their cheeks, that will assess the symmetry on both sides. Cranial nerve 8 is the acoustic nerve. So that's when we do that whisper test. So you can see that 8 is on the ears, and then 7 kind of makes up the face. And then cranial nerves 9 and 10. So cranial nerve 9 is glossopharyngeal. So you're just going to look at the back of the person's throat, see that the uvula rises symmetrically. The person says, ah, that's checking cranial nerve 9. And then if you touch the posterior pharyngeal wall with a cotton applicator and have the patient gag, that's cranial nerve 10, which is the vagus nerve, but we don't need to gag anybody, so we don't check that. Cranial nerve 11 is the spinal accessory muscle. You can see the 11s are on his shoulders. So if you have the person shrug their shoulders and they're able to do it equal bilaterally, that would be a normal cranial nerve 11. And then cranial nerve is hypoglossal. You would want to inspect the tongue, have the person stick out the tongue. You could ask them to say light, tight, and dynamite. That is clear and distinct. That means that nerve is working. All right, so the nurse is assessing cranial nerve 7 in the client who sustained a stroke. To assess the cranial nerve, which action should the nurse ask the client to perform?